Okay, so let's talk more about the um, lipedema reduction surgery um, paper. But what are we calling? What is
Yeah.
the
So
paper called? I feel
the
like I'm
title of the
sounding
paper
totally dumb
is
about that, but whatever.
okay. The title of the paper is Lipedema Reduction Surgery Improves Mobility, Knee
That's
Mechanics,
knee
and
mechanics. That was the key part I was talking about.
yeah, and quality of life in women with lipedema. And so, yeah, I'm very proud of the work. It's a great paper. We looked at over 500 cases of lipedema surgeries, and we before the surgery we measured their knee mechanics. That's the alignment of their knee, the flexion of the knee,
And also the degrees that they move, right?
yeah, and the degrees that they move. And then we also had them do surveys about and measured their gait, and that we had them do surveys about the about their mobility and about their quality of life and their experience of pain. And then after the surgery, we so this is we always do several follow-ups after each surgery, and we re-administer these tests to follow the improvements for our ladies. And so we found that their mobility improves significantly. This mobility improvement is actually correlated with increased life expectancy and decreased rate of disability or becoming disabled from lipedema. And so we found that their knee mechanics improved about 10 degrees of flexion, which is, quite significant. That's actually more than the average improvement seen with a total knee replacement. And so and their pain improved, their quality of life improved. And these things are very important because lipedema can be a devastating disease, and we need to make sure people understand that this is a medical condition and it should be covered by insurers. And so that really is what we want. We want to tell the medical community, patients, and the people that control the payment of healthcare that this is something worthwhile.
Yeah, and we even heard in one of the talks today that about how the knee, I don't know, was that called flexion?
Yes, yeah.
Was, so improved that the patient is actually going to be running an Ironman in 2 months, and so that's just astounding. Since I was diagnosed, I've added, I don't know, today, who knows what it is. Today I've probably 40 pounds since I was diagnosed, and one of the things that is exactly that the amount of flexion that, like I would like to take a picture, like if I'm crouching, and that it's never going to happen right now. So maybe if I, am reversed, whatever, if I can somehow get rid of some volume, that would be amazing. But yeah, I mean, I think there was mention of like the ease of going up steps, even with the flexion, is so improved. So, and then also, the obvious about the reduction in the heaviness of being able to move that as well. Should we talk about like because you did mention a bit, your personal follow-up plan, like you see people.
Yeah. So again,
so not everybody sees people. I'm just saying.
So that's part of our. So this is a lifelong disease, and it's not. And we've already discussed how nutrition and compression are important for it. Exercise as well, in maintaining this. And we follow our patients long term. I mean, this is not have a surgery, see ya kind of thing. This is we follow them at least at 6 weeks, usually 3 months, a year, and then sort of annually if needed, and that's how we approach our patients. And sometimes for patients out of town, we will follow them. We'll have virtual.
Yeah. So while you're in the, typically with a reduction plan, you're going to be expecting multiple trips, multiple surgeries. Right. Most people are in from out of town. We heard that, across the whole board yesterday, that everybody mostly had patients from out of town. So people travel to get to their surgeon of choice, and they, so you're going to be going every so often, if this is the route that you choose. But once you get to the final, then there's still follow-up care that, is really considered, because that's one of the biggest things, right? People are worried, like, oh, am I getting regrowth? Right. And how are you really going to know if you're not being followed by your surgeon? And like, when you choose a surgeon that's actually involved in like the research aspects, like these are things that, as we expand more into more, more funding, more grants, more things that we want to look at, there's, the surgeons have to look at this kind of stuff that are involved in those processes, right? Right.
So, I mean, it goes with our practice philosophy, but also it's the only way. Sure. It's the only way to fully understand the benefits that occur, because some of them really don't occur immediately. It can be a year. In the patient that you talked about, whose knee mechanics, that X-ray, you could see her crooked knee, and then afterwards the straighter alignment. Those were done 2 years after after she started the surgeries. So and we wouldn't see that if you're not following it, and so. But also there things come up. Are we having regrowth? We remeasure them. We follow these sophisticated things on their body mass, their edema, their measurements. All these things help us, better understand how people are living after their surgery as well.
Right. Which, of course, you're recommending all the things that you're recommending to be continued for life. These are not like you're just doing this before surgery and now it's the miracle drug and your,
right.
wand.
Yeah. No, unfortunately, don't have a magic wand. It does not cure lipedema. It is a disease that you will have for your whole life.
And it will have to be managed. So, is it true that you consider this a tool, like it's another tool that we have in our toolbox if somebody is able to go through a reduction journey?
That's right, yeah.
Mm-hmm.